Cameron. Welcome to the Recover Research Review, or R3 seminar. My name is Christine Bevick, and I'm a translational health scientist with the Recover Administrative Coordinating Center, and I'll be your moderator for today's seminar. The goal of the seminar series is to catalyze a shared understanding of the research within the Recover Consortium. And I want to start by thanking everyone who submitted questions in advance. You can submit any questions today during using the Q&A feature in the Zoom menu. And after today's panel, our speakers will answer as many questions as possible. A Q&A document will be posted with the recording of the seminar on recovercovid.org. The document will include answers for submitted questions relevant to today's presentations. Questions about other scientific topics will be addressed in future seminars, and answers to broader questions about Recover will be available in the FAQ found on recovercovid.org. As a reminder, we cannot answer individual questions about clinical care. Our presenters today are Dr. Suchitra Rao, Dr. Abigail Case, Dr. Melissa Stockwell, and our representative discussant will be Ms. Rebecca Letts. Dr. Suchitra Rao is an associate professor of pediatrics and an infectious diseases physician and hospitalist. She spent the last 16 years studying respiratory viral pathogens in children, with a more recent focus on influenza and COVID-19. She's one of the principal investigators for Recover's Pediatric EHR Cohort Initiative, and also serves as the site principal investigator for PedsNet, a large data network and learning health system spanning multiple sites across the country. Dr. Abigail Case is a pediatric rehabilitation physician and program director of the Pediatric Rehabilitation Medicine Fellowship at the Children's Hospital of Philadelphia. She also serves as CHOP's Quality and Patient Safety Champion of the Division of Rehabilitation. She is also an assistant professor of clinical pediatrics at the University of Pennsylvania. Her clinical interests include treating traumatic and acquired brain injury, inpatient rehabilitation medicine, and pediatric cardiac rehabilitation. Her expertise in functional assessment and management for pediatric patients has driven her involvement in the Recover Initiative and ongoing scientific efforts towards understanding PASC in children. Dr. Melissa Stockwell is the Chief of the Division of Child and Adolescent Health and the Felice K. Shave Professor of Pediatrics at Columbia University's College of Physicians and Surgeons. She's also Professor of Population and Family Health in the Department of Population and Family Health at the Mailman School of Public Health. She's a pediatrician in a New York-Presbyterian Hospital community clinic and is Associate Director of the American Academy of Pediatrics Pediatric Research in Office Settings Practice-Based Research Network. Dr. Stockwell serves as the contact PI for Recover's hub site at Columbia University, and she currently serves as the chair of the Recover Pediatric Cohort Coordinating Committee. Ms. Rebecca Letts has been a pediatric long COVID caregiver and long COVID patient since March 2020. Her youngest child brought home COVID from school and neither recovered afterward. As an early long hauler, Rebecca's become involved in multiple infection-associated chronic condition and illness advocacy organizations, chiefly engaging with the COVID-19 Long Hauler Advocacy Project. She joined Recover in June of 2021 as one of the first pediatric representatives, and she currently serves as a member of the NCAG Representative Engagement Subcommittee. She's an active contributor in multiple manuscript writing groups. The topic of today's seminar is PASC in Children, State of the Science and Future Directions. Today's speakers will discuss our current knowledge of long COVID in children, including the epidemiology and risk factors underlying mechanisms that cause symptoms and functional outcomes. And with that, I will hand things over to our first presenter, Dr. Rao.
Thank you so much, Christine, and really wonderful to be here today. So welcome to everybody who is joining live on the webinar, as well as those who are going to be joining at a later stage. So as you'd heard, we really are going to be taking the time today to be talking about long COVID as it pertains to children. And if we go to the next slide, I just wanted to disclose that I am one of the main principal investigators for the pediatric EHR cohort that is doing research into long COVID through the Recover Initiative. Next slide. So what I really wanted to cover in my portion of today's talk is to really go into the state of the science with regards to long COVID in children. So we'll talk about some of the epidemiology and risk factors of long COVID or PASC in children, and cover some of the presentations that we're seeing commonly in children and relate how that might be different to what we've been seeing in adults. And we really are starting to learn more about some of the underlying mechanisms of long COVID and its different manifestations. So we'll relay that back to what we know about long COVID in children as well. So if we go to the next slide. So really just to set the stage for what we're about to be talking about today, really soon after the emergence of SARS-CoV-2 back in a few years ago, we really a few months later started to see that some patients were recovering from the COVID infection, whereas other people were having more persistent symptoms. And these symptoms were lasting anywhere from a few weeks to a few months to even a few years after the initial infection. So there was a lot of research and understanding of what was happening with long COVID in adults, but there was still a paucity of information about what was happening with children. So many of us in the pediatric community were seeing these types of symptoms and manifestations in our pediatric populations. And the scientific community, the medical community, and the general community that knew more about this really urgently wanted the NIH and other scientists across the world to do more work into exploring long COVID and how it presents in the pediatric population. So really in response to that need, there is a pediatric branch of the Recover Initiative funded by the NIH that is solely focused on understanding PASC or long COVID in children. And the research that's being done by this group spans large sort of retrospective studies using EHR cohorts, as well as large prospective studies following people over time. If we go to the next slide. And before I launch into what we're seeing in the pediatric space, I just wanted to cover some of the definitions that you may be seeing or hearing about, just to make sure that we're all thinking about things the same way. So when we talk about PASC, we're talking about the post-acute sequelae of SARS-CoV-2, and this refers to the ongoing relapsing or new symptoms or other health effects that are occurring after the acute phase of SARS-CoV-2 infection that is present for 4 or more weeks after the acute infection. And this is a term that the NIH and the Recover Initiative uses a lot in their studies. Next slide. The CDC uses the term post-COVID condition, and the way that it's defined by the CDC is the continuation or development of new symptoms 3 months after the initial SARS-CoV-2 infection, with these symptoms lasting for at least 2 months with no other explanation. And if we go to the next slide, now the World Health Organization has also used a definition of post-COVID condition, which is a little bit different from what the CDC has been using. And more recently, they convened a group of experts to come up with a pediatric specific post-COVID condition definition. And that is here for you: at least one physical symptom persisting for a minimum of 12 weeks after initial confirmed infection that may continue or develop after COVID-19 infection, cannot be explained by an alternative diagnosis, and has an impact on everyday functioning and may fluctuate or relapse over time. So I do appreciate the pediatric focused definition used by WHO. If we go to the next slide. So the way that I like to think about the post-acute sequelae of SARS-CoV-2 is really represented in this sort of conceptual framework here. So some of these symptoms and conditions may reflect those persistent symptoms that were occurring from acute infection. So these might be things like cough, like headaches, like fatigue that occur with the onset of the viral infection. But these might also be symptoms that are arising de novo, completely separate from the acute infection. And these might include some autoimmune phenomena, dizziness, for example. Multi-system inflammatory syndrome in children would be considered one of these de novo type conditions. But then we also have to remember that it could also represent some of the exacerbations of underlying conditions that may have been preceding the acute SARS-CoV-2 infection. And we'll explore each of these different manifestations. So if we go to the next slide. So how common is SARS-CoV-2, the post-acute sequelae of SARS-CoV-2 in children? So there has been sort of a lot of work trying to answer this question with very sort of varied results. So what I'm sharing with you now is a meta-analysis and systematic review of a number of different pediatric studies looking to explore how frequently we're observing long COVID in children. And you can see there's a vast range of numbers starting at sort of 1% and going all the way through to 70%. And this wide range that you're seeing in the literature really relates to the differences of how long COVID is being defined, differences in terms of the study design from one group to another, the setting in which patients might be sort of enrolled in studies, the population of those children and adolescents, the follow-up period, as well as some of the ascertainment methods of how they're determining what those symptoms are. So if we focus just on some of those larger prospective studies that incorporate a control group that are well designed, those estimates from those studies are looking at more of a sort of 10 to 20% range within that first 6 months of infection. If we go to the next slide. So now just to talk a little bit about some of the natural history and other aspects of the epidemiology. So really less is known about the trajectory of PASC in children. So very few studies right now have examined outcomes beyond that 12-month period. And many studies with Recover are going to be exploring sort of that period and beyond. And so there was one study that was showing that about 30% of kids that were experiencing long COVID continue to have symptoms even at that 12-month mark. We know that people can have flares of long COVID. So with every subsequent COVID infection, you're at risk of having sort of a flare of your long COVID symptoms. And we also know that the overall prevalence appears to be decreasing over time. There were earlier reports of long COVID in kids during that early phase of the pandemic. And now in the Omicron and beyond, we're starting to sort of see less reporting of it. But I do want to emphasize that for those people who are still experiencing symptoms, these can be going into years after their initial infection. So if we go to the next slide. So we're also starting to learn more about the risk factors for long COVID. And I tried to pick ones that were relevant for the pediatric population. So we know that older adolescents are more likely to have long COVID than younger children. If you're female, you're at a slightly higher risk than if you're male. If you have a history of allergic disease, some studies have shown an increased risk of long COVID or PASC, as well as having a lot of medical complexity, so having a number of medical comorbidities. The severity of your acute COVID is also a risk factor. So if you were hospitalized or in the ICU, you are at higher risk of having long COVID symptomatology. And as I mentioned, the pre-Omicron period is a greater risk of having those symptoms. It appears too that the number of organ systems that were involved during the acute infection is a risk factor for long COVID development, as well as increased weight status. And as I mentioned, you can have flares or bouts of long COVID. So the more repeat infections you have, the more at risk you are. And there are numbers of studies that talk about the social influences or social drivers of health, that one sort of environment and vulnerability could also put someone at risk of having more prominent symptoms. And we can talk a little bit more about the vaccination story, but we do know that vaccination is a protective factor. So if you're unvaccinated, you do appear to have a higher risk. If we go to the next slide. And we know that long COVID can really virtually affect any organ system in the body. And so here is just a summary of some of the conditions and the symptoms that have been described in children by different organ systems. And as you can see, it can really range from everything from respiratory manifestations to things affecting your hematologic system, skin rashes, GI manifestations, a lot of constitutional symptoms, and sort of neurodevelopmental, neurocognitive symptoms as well. So we're going to talk about some of these common symptoms that we're seeing in children over the next 45 minutes or so. So in terms of, if we go to the next slide, if we want to think about how some of these symptoms are manifesting differently in children compared with adults, I wanted to just share with you a study that was sort of an example of looking at these differences. So this was published in Scientific Reports earlier this year, and it was looking at a population of children as well as adults with long COVID and looking at differences in their presentations. So the two boxes on the top are showing you the top symptoms that were experienced in adults on the left and then on the right in children. And so if you just focus on that right top box for now, some of the top symptoms that were being reported included cough, fatigue, headache, sleep disorders, as well as difficulty concentrating. And then if you look at the box just on the left, then a lot of those symptoms were also being exhibited by the adults, but just in sort of different reported frequencies. So in summary, a lot of the symptoms that have been reported in adults are also being seen in children, and that there's definitely some sort of different variations of long COVID in kids. So some of these other studies that have looked at some of the differences do report that the recovery appears to be sooner or faster in children compared with adults, just kind of talking sort of generally, and that there appears to be some features that appear to be more frequently seen in kids, and rash would be a good example of that, dermatologic manifestations, as well as some of the GI manifestations. So if we go to the next slide. So we also did a study trying to explore some of the more frequent manifestations of PASC in children. And so these are just some results of a study that we published a couple of years ago. This was looking at a cohort of close to 660,000 children who were tested for SARS-CoV-2. This was across 11 to 12 different pediatric hospitals around the nation and included hospitalized patients as well as outpatient children. And we looked at the frequency of certain conditions and symptoms in the test positive group and compared that sort of relative frequency to the test negative group. And so the graph that is shown on the left here is looking at some of the different symptoms. And you can see that some of the common ones being reported were other changes of smell and taste, hair loss, chest pain, abnormal liver enzymes, and generalized pain. And then the panel that you see on the right is referring to some of the health conditions that were associated in our cohort. And so we see here myocarditis, acute respiratory distress, myositis, and the need for mental health treatment. So there's clearly some differences that we've been seeing in terms of what's being reported in children compared with what's being reported in adults. If we go to the next slide. So we are really starting to understand a little more about the underlying mechanisms of long COVID in adults as well as children. So there's a number of different proposed mechanisms. We know that there is definitely going to be overlap with what we've been seeing in adult studies compared to pediatric studies, but we definitely need more pediatric studies really reviewing the mechanisms since there may be quite important differences in just how children are sort of manifesting with their pathophysiology. So I just wanted to share a few of the underlying mechanisms that have been sort of proposed to date. So one of them talks about immune dysregulation, where you have your immune system that is supposed to be targeting the virus, ends up having this sort of dysregulated response or an exaggerated response, or one particular arm might be sort of more upregulated than another. And that dysregulation can lead to sort of inflammation, and sort of innocent bystander organ systems can get infected. The second is a microbiota dysbiosis theory, where if you have viral persistence, it can stimulate disordered microbiota, and that can put you at risk of sort of GI and potentially systemic manifestations. The next is a molecular mimicry theory, where you have antibodies that should be targeting the virus, but end up going on to attack cells in the body and can cause destruction either sort of locally or more generally. And then we know that SARS-CoV-2 is a prothrombotic state, so that can lead to blood clotting and endothelial abnormalities that can also sort of affect certain organ systems. And then finally, there's also a theory about dysfunctional neurological signaling, where that can then impact some of those sort of neurological and as well as systemic manifestations. There are other theories that have been proposed and have been studied, one including the latency of viruses that are already in the body being sort of re-stimulated, and the mast cell activation syndrome theory as well. So if we go to the next slide, what I wanted to do next was just go over some of the more common manifestations that we have been seeing in children. And I wanted to just provide a couple of examples of what we know about some of the pathophysiology to help explain some of these symptoms. So in kids, some of the more common symptoms that we've been seeing have been including things like fatigue, malaise, post-exertional malaise, chronic fatigue syndrome or ME/CFS, post-COVID fatigue, aches of the muscles as well as the bones, cognitive difficulties, brain fog, persistent headaches or migraines, as well as dizziness. And in terms of some of the pathophysiology that has been reported, there is a concept of neuroinvasion leading to neuroinflammation that can then go on to cause tissue damage of the nerves that can also then result in impaired clearance. So usually you have these microglia that will help to clear debris, and that impaired clearance is also contributing to some of these symptoms. And there's also a theory about microclots that might be causing some sort of microvascular changes in the brain that may also be contributing. Studies have looked at different neurotransmitters and also found decreased levels of serotonin amongst many of the patients that have been experiencing some of these cognitive difficulties and brain fog. If we go to the next slide. So I also mentioned that the respiratory manifestations are very commonly seen in children, and these can be manifesting as persistent or more chronic cough, as chest tightness, as shortness of breath at rest and with exercise, chest pain, as well as exertional fatigue with functional limitations. And again, what we're seeing here is when the virus comes along and binds to the ACE2 receptors in the upper and lower respiratory epithelium, you end up with this sort of excessive inflammatory response. That can then lead to irreversible lung fibrosis and sort of local damage to the parenchyma, as well as lung vascular damage in the microvessels and the microthrombi that may be preventing that appropriate sort of exchange of gases across the alveolar membrane. And that can then lead to compromised respiratory function. If we go to the next slide. So now I want to talk a little bit about some of the cardiac manifestations of PASC or long COVID in children. And again, these are relating to things like myocarditis, to multisystem inflammatory syndrome in children, to conduction abnormalities and arrhythmias, as well as postural orthostatic hypotension and tachycardia syndromes. So what more research into POTS has been revealing that the acute infection triggering of the immune system is leading to antibody production. And so some of these antibodies are binding to the ganglionic adrenergic muscarinic acetylcholine receptors. And that might be then promoting dysautonomia that then relates to POTS. So more sort of research is being done into that pathophysiology and seeing if there are ways to overcome that. If we go to the next slide, I wanted to also talk about some of the GI manifestations. As I mentioned, we're seeing a little bit more of this frequently seen in children. And so these are manifesting as things like chronic abdominal pain, vomiting, having loss of appetite, diarrhea, and weight loss. And there's some interesting work that is being done in both pediatrics as well as adults, looking at what is happening at that sort of mucosal level within the gut. And there have been a number of reports showing the persistence of SARS-CoV-2 virus in the GI mucosa that can then lead to dysregulation of the ACE2 receptor-mediated functions. That persistence is leading to a lot of mucosal microinflammation, and that can lead to translocation. So microbes that really need to be hanging out in the lumen of the gut are now translocating and getting into sort of underneath the mucosa and then into the blood vessels and getting in systemically. And that can then cause dysregulation of the intestinal barrier, and you get this distorted microbiota, which then can lead on to having GI manifestations. And there are some interesting studies underway looking at whether there's a relationship to what we're seeing with the gut microbiome, as well as what might be happening more systemically as well. And then I just wanted to also show the next slide here, which is just to touch upon the fact that we can also be seeing exacerbation of underlying conditions. So these might be manifesting as children with asthma, having a lot of asthma exacerbations, of having acute pain states amongst people who have fibromyalgia or connective tissue diseases. It can lead to worsening hyperglycemia, for example, amongst people who have type 1 and type 2 diabetes, as well as the exacerbation of things like sickle cell disease. And if we go to the next slide, I also wanted to touch upon some of the new conditions that have been associated with development after COVID-19 infection. So these would be considered those de novo ones, separate from any of the acute symptomatology. So you might be familiar that there have been studies that have demonstrated an increased incidence of both type 1 and type 2 diabetes during the pandemic after SARS-CoV-2 infection. There have also been a number of reports of autoimmunity arising after SARS-CoV-2 infection, including idiopathic thrombocytopenic purpura, Graves' disease, lupus, antiphospholipid antibody syndrome, vasculitis, myocarditis, Sjogren's syndrome, with findings of autoantibodies after the acute infection. And then as an infectious diseases physician, I've been consulted many times on some of these post-inflammatory neurologic conditions, such as meningoencephalitis, optic neuritis, anti-NMDA receptor encephalitis, and GBS. And so, again, I think more of an understanding of what is happening to promote these sort of new conditions is really going to be a sort of an active area of research. And if we go to the next slide, so there's still a lot that we need to know about the manifestations and sort of prognosis for children and adolescents with long COVID. We need to do more sort of focused study of sort of underlying mechanisms in pediatric populations, with the hopes that we might be able to come up with some sort of biomarker for PASC that can help with the diagnosis or identifying those who might be at higher risk. We need to do more studies into the natural history of PASC in children, so follow these children really over long periods of time, and then also to think about what treatments are effective to prevent or treat PASC using really rigorous methodology, really good evidence-based directions on how to manage patients or prevent their manifestations. So I just wanted to finish my portion just by acknowledging, if we go to the next slide, just wanted to acknowledge the team of people that I work with on the Recover Initiative, including folks from PedsNet and PCORnet, and the folks that are involved in the Recover Initiative. I also wanted to acknowledge the co-authors on a recent manuscript that we published in Pediatrics, which was a collaboration between the EHR group, as well as the prospective cohorts, as well as some of our parent and family and patient partners. So thank you so much, and I'll hand it over to our next speaker. Thank you.
Hi, good afternoon. I am so pleased to be here today to talk a little bit more about functional outcomes in children and adolescents with long COVID. So the objectives of this portion of the talk are to describe the importance of rehabilitation and tracking functional outcomes in long COVID in children, to go over what's known about functional outcomes with patients that have long COVID, and to consider the next steps in advancing knowledge in functional outcomes in children. Next slide. So just as a bit of a background for those that aren't as familiar with rehabilitation medicine, we focus on function in all domains and across many different settings. Early on in the pandemic, it became quite clear that rehabilitation was going to be really important to a lot of patients that were suffering from acute SARS-CoV-2. And later on, as patients continue to have persistent symptoms, that they may also benefit from rehabilitation in the outpatient setting as well. Several studies shown that early and continual rehabilitation, evaluation, and treatment was beneficial to those recovering from infection. And as a way to really disseminate information quickly, a lot of organizations got together, like living guidance or rapid living systematic reviews, trying to disseminate what expert opinion, although there weren't large prospective high-powered studies, but to try to get information out there to meet this demand of a growing body of patients that had functional impairment. The World Health Organization had a living guidance statement. Cochrane Rehabilitation had a living systematic review that was updated quarterly, and the AAPMNR had multidisciplinary consensus guidelines on the most common post-COVID conditions. And while it was great that this information was out there, it was incomplete because it is only in smaller single site studies and expert opinion. Next slide. So before we talk about what the ideal outcome measures might be, it's important to talk a little bit more about what we mean by function. And so thinking about having a common language set to talk about disability and impairment. And in 2001, the World Health Organization came out with the International Classification System for Functioning, or ICF, and in 2007 it was expanded to children and youth, so the ICF-CY. And these are a way to structure and organize language talking about function. And when we say function, we mean the complex interaction between any given health condition, the body structures and the way they function, activity and participation, as well as contextual factors or environmental factors. And so when we think about obtaining outcomes measures to track patients' function, it'll be important to have clinician-based assessments, so potentially more objective information using validated tools and instruments, and patient and parent-reported outcome measures to really capture the patient and family's experience as well. Next slide. And so the importance of functional outcomes can't be understated for the Recover Initiative, which, as we mentioned before, is seeking to characterize but also to inform future treatment and prevention efforts. So tracking functional outcomes can allow us to determine a baseline status, potentially have clinical trial endpoints, monitor treatment effectiveness, assess changes in function, and hopefully predict prognosis more accurately. Next slide. As a rehabilitation medicine physician, we think about the different domains of function. So on the shorter term or acute, we think about mental status, sensory function, communication, motor function, feeding ability, and respiratory status. And then we have longer term domains, which are more subacute or chronic, and that's cognition, school or work performance, ability to perform daily routines and maintain relationships, getting good quality sleep, and mood. Next slide. So now just to talk a little bit about what is known about functional outcomes. So I can say early on, there was an explosion of information being released, lots of single site studies talking about the acute outcomes and mortality of SARS-CoV-2. And since then, there have been some looking at the more subacute or longer term, but not many. And there aren't many studies that are looking primarily as functional outcomes as their primary outcome measure. The clinical manifestations of PASC or long COVID continue to be well recognized and further defined, but there are a few studies that have shown decline in function in adults following SARS-CoV-2. And not only that, but they've shown reduced health-related quality of life, looking at parent or patient-related reported outcomes, reduced occupational performance, and then in one multi-center prospective study, which does tend to be more nationally representative of the population, it showed 11% of survivors not returning to work due to poor health. Next slide. So despite the growing body of literature on long COVID in children, there are few, if any, studies looking at how these persistent symptoms impact daily function and quality of life. Further, there's no tool or validated instrument to help clinicians track or measure these outcomes. In the adult population, there has been a tool developed, which is called the Post-COVID-19 Functional Status Scale, which is an ordinal scale, which is not a new concept. Ordinal scales are helpful because they're simple tools that can be applied quickly and to heterogeneous populations. But these tools have not been developed or validated for the use in adolescent or children. Next slide. So developing an outcome measurement in pediatrics is kind of a tricky or a balancing act. It's been a challenge to develop, and this is in general for pediatric populations for any disease, but especially in long COVID, because it has to span all the developmental stages from infancy to adolescent. It has to be well-defined and sufficiently rapid yet reliable, minimally rely on subjective assessments, and applicable to as full as possible age spectrum. So this is a difficult act to ask, but and in some situations you may have to sacrifice potentially how rapid it can be done to apply to a larger population. But again, trying to really encapsulate all of the factors that go into measuring how long COVID's affecting children. Next slide. So as I said, few studies looking specifically at functional outcomes. Some of the studies that we've seen have had secondary measures or descriptive information that can extract functional outcomes. So in this retrospective cohort study, looking at pediatric patients that had MIS-C or multi-system inflammatory syndrome in children, there was little organ-specific sequelae, meaning that all of the lab work and further studies like chest x-ray were negative, but patients had physical mobility and mental health support needs. And so this really highlights that despite gaining information about patients, these functional deficits or impairments are there, and perhaps we didn't have a sensitive enough way to measure it. And so that was important to note. Next slide. And again, looking at a descriptive study of patients that had PASC. And so these were patients in a single site study at a large academic institution where patients with already diagnosed long COVID were presenting to a pulmonary clinic. And they had many reports of persistent dyspnea and cough, but their pulmonary function, chest x-rays, echocardiograms were all normal. But they did have an impaired 6-minute walk test, which is a validated measure often done by physical therapists, looking at how long or how far patients can walk in 6 minutes and tracking different symptoms that may pop up during that test. So this all, again, suggests that there are functional limitations that are persistent, but not necessarily being able to be picked up on. Next slide. So, the next steps from how I view this is how can we try to encapsulate or capture the functional impairments that we're seeing? And I think it's going to be utilizing different tools and asking different questions. So an important part would be to utilize PROMIS or patient-reported outcome measure information system and instruments, which can measure these are validated tools that can measure different areas like pain, fatigue, function, depression, anxiety, and social function. And these have been used for different disease processes in both adult and adolescent and children that could be applied to potentially long COVID. Next slide. In addition, there are several validated pediatric outcome instruments that are commonly used in different disease process that might be important to take a look at. Just of note, these are used in different settings and in different age ranges. So an example, the functional status scale or the FSS is typically used in an intensive or acute care setting and has been applied to track some of those acute domain function that we were looking at in ICUs for things like sepsis. And then in the outpatient setting, you can use things like the Bayley scales of infant and toddler development for younger children that you may be concerned, all the way from a functional independence measure or FEM, which we use in inpatient rehab as well as an outpatient to track and monitor functional independence, which uses domains of communication, ADLs or activity of daily living, functional, as well as cognitive. Next slide. These are also cognitive screening tools that are from the NIH toolbox, but that should be potentially used to capture any cognitive impairment that may be happening, validated for different ages. And so I like the idea of a toolbox because there may not be one measure that is going to capture everything for the wide or heterogeneous disease of long COVID. But the other thing to note are these battery or testing take varying lengths of time, and some require materials, and some are looking at more executive function versus memory processing. And so really, depending on what the symptoms are, the age of the patient, and the tools at hand, you may choose to use a different tool. Next slide. So I spoke about these earlier, the short-term domains. So these are, if we can just hit next slide. These are some of the questions that may come up if you were trying to assess this in real time, thinking about if a patient's having a change or difficulty expressing themselves, for motor, difficulty walking, were previously able to do activities that they aren't now, feeding ability, respiratory status. So these are questions that we should be asking when we're examining or taking the history of patients that have potential long COVID. And if we hit next slide one more time, these are the ways it might manifest in terms of a patient's function. So it could show up as increased reports of behavior concerns or school absences or increased referrals to specialists. Next slide. And so that's in the acute setting. And then in the longer term, we really focus on some of the translation of earlier, Dr. Rao was talking about some of the specific symptoms and the potential pathologic or mechanisms of how they are affecting patients. And these are the ways that the end product, how they might look and what questions we should maybe be asking. Next slide. So thinking about memory concerns or forgetfulness, has a patient's grades dropped? Are they requiring a new or updated support? 504 IEP? How are they participating in school and their extracurriculars, maintaining friendships, relationships with family, their sleep and mood disturbances that can all be affecting and may, again, present or be seen as, next slide, increased referrals or behavior reports, need for more specialists, increased school absences. Next slide. So now just a bit of practical information here, thinking about how can a pediatric rehabilitation specialist be helpful if you think a patient or if you yourself have a contact that might have long COVID. I think this was easier for clinicians to identify when, at the early stages of the pandemic and there were more severe presentations. Patients having really significant and severe functional changes, it became clear that rehabilitation was needed. And I think it's been more difficult in the outpatient setting for a number of reasons, partly due to the limited guidance, due to the low quality of research and anecdotal reporting. There's such a wide spectrum of illness, and throughout all of this, some patients are recovering, so they may have symptoms of long COVID or PASC that then recover before they're ever even diagnosed. And there's overlapping psychosocial concerns. But reasons I can think to refer to a rehabilitation specialist are if a patient had a complex medical history in the past, they've had existing functional impairments, and you're noticing that they've worsened. So patients that may have required physical therapy or occupational therapy, speech therapy in the past, if they've had a significant functional status change, so they've gone from being able to be a high-level athlete to now just barely being able to get out of bed, move around, that would be a significant function change. And especially if you're in a limited resource area, you may want to consider trying to partner with local rehabilitation teams, including neuropsychology, for additional resources. And so that was the bulk of, next slide, what I wanted to talk about with functional outcomes. In summary, I think we need to be tracking using a variety of tools and measures that can get more objective information and larger prospective studies to really capture how this is affecting children on a day-to-day basis. Thanks.
Thank you so much to the both of you. This is really an amazing review of what we know so far about long COVID in children, adolescents, and young adults, and really how profoundly long COVID can affect them in their daily lives. And also illustrates how much we still have to learn. There's a lot of unanswered questions. And I think that's really helps illustrate so well the importance of the Recover initiative overall, but I'm going to focus on the pediatric cohort since that's what we're all involved in. And some of the really key questions that we are trying to tackle and discover and uncover in the pediatric cohort is, why do some children get long COVID and others don't? You know, what causes long COVID to happen? What are some of the symptoms that children feel? How long do children feel sick for? What do we know about relapse and recovery? And then how does long COVID affect not only both the current physical health, mental health, and development in children, as Dr. Hayes mentioned, but also what about later? How are kids going to change as they develop and as they grow older? What's going to be the impact of long COVID? And just to reassure everybody, we are using a number of the promise measures and the NIH toolbox, both of which Dr. Case mentioned. So we really do hope to, particularly for the functional outcomes, it's a really big focus of ours in the pediatric cohort. So I wanted just to open up the questions first. I have a few questions first before we open up to the greater audience. And I want to focus first on talking to Becky. Becky, thank you so much for being here today. And really, you have given so much to the Recover initiative. And this is just one of the very, very many things that you were doing as part of the initiative. So thank you so much for all of that. So my first question for you is, can you talk a little about what are the reasons that you had for joining Recover in the first place?
Well, when I joined, pardon me, when I joined Recover, I'd actually already had long COVID for about 15 months. And at that point, it felt like a lifetime. And I say we because the long COVID community became a community early on because we had to. There was kind of a lack of help. We had to figure things out on our own. And so I was recruited when Recover was in the planning stages to be part of the pediatric cohort. And I had many reasons, but before I got sick, I was used to doing things and getting and helping. And it seemed, and my other long haulers agreed that best way to help in that circumstances would be part of the change. We really agreed with the idea of sorry. Wow. I am a long hauler myself.
Yeah,
maybe I should back up a little bit. Maybe I should
Yeah.
back up a little bit. I have long COVID, and I've had it since March 2020. And my youngest son of 3 also has it. And we've had to really kind of dive into the science because no one was doing it for us at the beginning. And so we as in long COVID patients are going to be part of the process step by step. And I've always wanted to be doing things. And when you stop being able to physically do things, you want to do as much as possible. And so I was happy to be there. Also, the kids with long COVID desperately need someone to be there speaking for them. What my son had gone through already at that point was something a child should never have to go through. And honestly, he had it easier than the adults, but to be a child, it's not, it wasn't okay. Um, I think some of the adults with long COVID and chronic illnesses in general have to seem to break pretty frequently and have to pick ourselves up and put ourselves back together. And to see that in a child is tragic. And I wanted to speak for the children so that that wouldn't be forgotten, and the experiences of both my child and all the other children in the communities that I was part of, thousands of other families just like mine could be represented as well.
Really, it resonates so much. I think that those are so many of the same reasons why there's so many pediatricians that got involved with Recover, that we really you talk about being the voice of children. Like, we really think that we are the voice of children as well. And you and all the other patient and parent representatives are such an important part of Recover overall, and the pediatric cohort specifically, because you are the voice, helping us to be the voice of those children. What do you think are some of the primary concerns that parents and children, at least, or older children who are old enough to voice their own concerns, have about pediatric long COVID?
I think the biggest concerns are, first of all, be heard, be listened to and heard. And then we're concerned about the future outcomes. What is going to happen in the future with these children? Many patients and many long COVID families are reading the studies, are actually paying attention to what's happened in the past with other infections. And I want to make it clear that what is going on in my family is not unusual. So what I found out in this whole journey that I don't wish on anyone is that this is not abnormal. I have complex chronic illness, and I should have known before. Long COVID actually set it up for me to figure out that I should have had completely different treatment my whole life. And so many other people should have too, thousands and thousands of other people, because not only did the medical system not have it wasn't prepared for chronic illness and infection associated chronic conditions with COVID. It wasn't prepared, so it wasn't prepared before. The vast majority of the medical providers, the long COVID community ran into at the very beginning of the pandemic, it's much different now, I would like to say. The very beginning did not expect COVID to did not expect a virus at all to make people sick and not get better. And that's the experience the patients had. And I don't, it's not an accusation, it's just our experience. And so we need the this the system to like to be different in the future for our children. So like for my children, I'm doing something different. So the patients with long COVID, and so what I did is I kind of went on a journey kind of going backwards, discovering that COVID made all of these things much, much worse in both my son and my other children too, who would be diagnosed with long COVID if, like, in the strictest sense. But compared to my other son and me, they're fine. I mean, what can you do? They also have the genes for, we have hypermobility, we have Ehlers-Danlos syndrome in our family. So that hypermobility is now a risk factor for long COVID, and that's published. But 3.5 years ago, the long COVID community was saying the same thing. Yeah, sorry.
No, you're doing great. I know that you have talked a lot about, you talked about now, and you talked about before about, you know, obviously being a patient yourself, and that you're really here for all your children. And I know that as you said, your children are affected differently. I think we had a slide. I think we're hoping we'll get put up.
Yeah.
So I think that slide. Yeah, there we go. Perfect. Oh wait, go back one. Yeah.
With Alex, so my long COVID child, Alex, he was actually the first one sick of all of us. He came home from the last day of in-person school ill, but we didn't know he was ill. It was over the next week. And his symptoms were not on any COVID list at that time. The children really do have COVID differently. And it's important, I think, that physicians don't write off anyone's illness because it doesn't present the way they think it's going to. When in the first months of the pandemic, when long haulers were first getting sick, and the adults were very sick, we still were talking about our children, and all of them had symptoms that lasted. Not all of them, but a fair number of them had symptoms that lasted a while. And there were a great number of rashes, and fevers and GI symptoms, definitely. But we didn't hear anything about this, in the news, except that children were not affected by COVID. And we had a different experience, but of course our kids didn't have tests or anything because we didn't have tests. And so we wished that we could give that information somehow to wherever it could be useful. But at that point, nobody was asking for information about children, data about children. And if they were, they would want a positive test. So
I think there's so much that we
yeah.
we have learned about how COVID acutely looks different
Yeah.
over time,
Yeah.
and then
yeah.
overall.
Yeah. My son and I became, our immune system became dysfunctional. So we did get many reinfections after that, especially me. But with each of the reinfections, we got new chronic symptoms or conditions. And one of them was the absolute worst for my son. He got PANS on his second reinfection. It's post-acute, shoot, what is it again for? I have that written down.
Is an autoimmune neurological.
Yeah, let me see what my brain doesn't want to remember anything. It's pediatric acute onset neuropsychiatric syndrome. So much easier to say PANS, but that is absolutely the worst. It is worse than long COVID in general for him, because he had managed to be able to go back to school with long COVID with a 504 plan at school, and missing, he was missing a day or two each week of school, which was bad, but he was slowly getting better. And then with the second reinfection, he got PANS and he had to go out and home hospital education, and he became a different person, like with flares. And it's brain inflammation that will cause rage and suicidal ideation. I can't say the word. I need someone else on here to just like ideation to help me with words. My kids help me with charades. And he couldn't talk or really communicate much for at least 6 weeks, and then it was not great after that for a long while. So he's back. That was over 2 years ago when that first started. So it was because he already had long COVID, because I was in the long COVID all the long COVID communities, including the pediatric ones, and that he had all these specialists that he managed to get diagnosed and helped within a couple of months, because the day the PANS was triggered, I looked at it and I thought, this could be PANS. And we contacted his pediatrician, had an appointment, a virtual appointment that day, and made appointments with his doctors at UCLA. He's in the POTS pediatric clinic, and they none of them would have suggested PANS, but I suggested it, and they're like, could be, maybe, I don't know, which is fine. But they agreed to refer him to a PANS specialist. And when he got there, when he got there, he got diagnosed. And the average, like all of these chronic illnesses, the normal average time to get diagnosed is 7 years. But what it looks like when it doesn't get diagnosed is kind of scary, because the kids look like they've lost their minds.
I think
and so it's a lot of psychological diagnoses.
And I think that's why it's so important that the pediatric recover cohort is really, we're really trying to look at all of these angles. And I think that your it's so whenever you share a story, it's always so hard for me, because it just to think of like how your children you and your children have suffered so much. And I think the hope is that doing this kind of research will answer, one, will answer questions, will get more children and families help. And I think your story really outlines so much of the different symptoms, the functional outcomes, all of those things. And thank you so much for being here and sharing. I know it's not easy on many levels, and your as I said in the beginning, I think the amount of time and input and everything you've given to recover is really amazing, really amazing. And thank you for all of that.
People understand the lack of executive function that I have.
Yeah, no, it's hard. I mean, I fortunately don't have long COVID. I have had COVID, and I know what that feels for a very, very short period of time, and I can't imagine what it's like for you. And and thank you again so much for sharing. I realize that I want to leave time for some questions from the audience. I'm going to ask like 2 super quick questions to Dr. Rao and Dr. Case. So Dr. Rao, I know you touched about being unvaccinated is a risk factor potentially for long COVID. Can you tell us a little bit more about that? I know you have a whole other paper on that and you didn't get to touch on it. But if you just want to have anything else you want to share about that.
Yeah, definitely. So, I think a very important topic that has been coming up with all of this is what is the role of vaccination in long COVID? Can it prevent symptoms from occurring or the development? So there was a study that we did and published very recently in pediatrics, and there was actually an R3 webinar series on it that was done by Hanya Razagi, who was one of the first authors on that paper. So for folks more interested in an in-depth, highly recommend watching that webinar. But we looked at our data from multiple different health centers across the country, over 1 million children, and looked to see whether vaccines could sort of prevent development of long COVID. And we looked at different definitions of long COVID. There was one that was sort of a more stringent definition. And so when you looked at that, we did find that there was a protective effect of vaccines against the development of long COVID. And so it was around 42% for that more stringent definition. And it was even more protective, so closer to 60% if you looked at sort of adolescents within that first 6 months after receiving a vaccine. We did see that effect did wane over time, so that is just again, I think, just promoting the benefits of getting those sort of both booster doses or the recommended schedule of those vaccines, but it did appear to have a protective effect. Yes.
Thank you. As a vaccine researcher in my other life, it's always good to know. So Dr. Cates, I know that some parents aren't familiar with rehab medicine specialists, and thank you for actually talking about it and kind of what you do. And I know that a lot of rehab medical doctors take care of children with many different kinds of conditions. But do you have any suggestions for parents if they're referred to a doctor, a rehab doctor, and who might know a little bit less about long COVID? And what do you think are some of the important highlights that they should share?
Yes, thanks. That's a great question. We are a small field, so in terms of working with a rehabilitation specialist, we really operate under diagnoses of impairment. So, if you potentially, we work with children that have cerebral palsy or muscular dystrophy, and they may have muscle weakness, but we're treating the muscle weakness, not necessarily the diagnosis of cerebral palsy. So I think about that for families or patients and parents that are coming to talk about long COVID. While it would be really important to highlight the context of the functional change, so potentially like we all had an infection, we tested positive for SARS-CoV-2, 6 to 8 weeks later, X, Y, and Z happened, but then really highlighting what it is that the patient was able to do before and what they want to get back to. So it may be crossing different spans or domains. It may, have some cognitive pieces as well as physical, but if you can highlight what you want to work on, then a rehabilitation specialist can kind of troubleshoot different techniques, referrals to different specialists like neuropsychology or psychology to work on memory retraining, or maybe it's partnering. One of the things that I've done commonly as a rehabilitation specialist is partnering with schools as to exactly what a patient needs in an IEP to be successful. And so just really having them kind of help walk with you in this impairment and try to return to optimal function.
Thank you. Thank you so much. I'm going to turn it over to Christina, who I think is going to be moderating the questions that are pouring in.
Yes, thank you. Thank you, Dr. Stockwell. Yes, we'd like to turn to some of the questions that have been submitted both in advance and during today's presentations. The first question I want to ask to both Dr. Rao and Dr. Case is around actually this one's to Dr. Rao, around the evidence of flares of long COVID in persons with long COVID and after other subsequent non-COVID infections. And if you can speak to that.
Yeah, that's a great question. So we have certainly seen anecdotally these reports of people having another viral illness and then having flares of their long COVID symptoms. It's not something that's reported a lot in the literature. I think it's a very important sort of topic area, but it is something that we see with our patients that we're sort of following over time, that this can happen not just with not just with SARS-CoV-2 positive infections, but we've sort of seen it occurring with others potentially as well.
Right. Thank you. And along a similar line around immune response, I believe you mentioned the allergies that put children at higher risk of developing long COVID. Is that any kind of allergy, or can you expand and provide a little bit more detail around that?
Yeah, so there was a report that came out of Nature that was looking at, again, sort of risk factors for long COVID. This was a study that was done in adults, but some other studies in kids have sort of shown this association as well, that if you have a history of allergies, and they looked at any kind, so it was seasonal as well as some food-related allergies, that if you had that sort of predisposition, that was considered a risk factor, which is sort of an interesting thing to see being reported in different types of studies. So then those types of studies, as well as sort of other ones looking at sort of pathophysiology, wondered about a mast cell activation syndrome as being a proposed mechanism for some of the features of long COVID. So the tachycardia, the flushing, some of the POTS manifestations, even some of the neurocognitive things. And so there have been some folks that have looked at whether we can do anything to sort of minimize that histamine release, and will that sort of impact treatment. So still work that needs to be done in this area, but it was just a risk factor that was picked up, a theory that makes a lot of sense, and then now studies that need to get done to sort of explore that association more.
Thank you, Dr. Rao. Dr. Case, related to rehabilitation, have you found that any treatments or medications that are working differently in children than they are for adults in PASC?
That's a great question. So I can't say that there's a lot of medication that we're seeing in rehabilitation at this point, although maybe in the future. But right now, some of the treatments that we have found to be more, and this is again anecdotally or in clinical experience, to be effective are some of the brain retraining and cognitive behavioral therapy. In general, it's thought that the pediatric brains have more neuroplasticity, but again, this is all still very new in terms of tracking outcomes and potential.
And Dr. Stockwell or Dr. Rao, feel free to, on any of these questions, if you'd like to also come off of mute and share your responses to add to the discussion as well. Um, scrolling through, we've had some really great response to today's panel and the discussions. And the follow-up question is related to the providers and being what would you suggest to providers and other practitioners in terms of being able to help recommend uh, for primary care physicians and pediatricians that may not know about long COVID, that this may affect the outcome of the treatment and the care that they're provided, that could determine the health status. Are there any short-term trainings that providers could undertake or feel better equipped to provide care for long COVID patients, and at least to do the right referral?
I can actually jump on this one quickly. There is actually the American Academy of Pediatrics on their website actually has a really great outline for pediatricians about long COVID and does kind of walk through a lot of the domains in the similar way that Dr. Rao did and actually talks about each and like when you might want to refer. And so that's often where I point pediatricians to if they want to learn about long COVID. We definitely hear in Recover from a lot of the families in the study that their pediatricians don't really know about long COVID, and they are finding them that they do have to be the educator. And I think similar to Becky's experience, and I can see some of the sometimes the questions that are coming in that really having to feel, which is unfortunate, they have to be educating the pediatrician about it as opposed to the pediatrician already knowing about it. I think one of the reasons why we did publish the paper in pediatrics that Dr. Rao mentioned was really to try and get out information about long COVID very broadly to pediatricians. Recover also does have a nice tip sheet, actually, that talks about if you want to, how to talk about long COVID to your pediatrician if your pediatrician doesn't really know a lot about long COVID. And so that's something that came out of the Recover Pediatric cohort as we were hearing from families that they really needed to have a way to help talk to their pediatrician about it. So we have a long way to go, but hopefully we're starting to make some changes. I don't know if Dr. Rao, you had anything else, or Dr. Keys?
Yeah, I was actually going to say all the exact same things that you mentioned. And I really like the AAP website. I know the CDC has put out some materials as well. When I talk to providers about these types of things, I think it's obviously important for us to sort of learn more about the conditions. It is important for us to think about that biosocial model of just thinking about ways that we can sort of help the child and the adolescent sort of really be at their best sort of capacity and their best potential. And then I think just as important is to really take the time to sort of listen to the child, to the families, to the parents, to their stories and what they're experiencing. There's still some disbelief out there about just the extent of these symptoms and conditions. And so I think really one of the most important things is just to take that time to sort of hear what's happening. It is an evolving field. We are learning more and more by the month. And I just wish that we could, proceed in a faster pace and try and come up with answers and treatments and make this all sort of go away. So I think that validation of just this is not in your head, this is real, we believe you, will help you through this, can really go a long way.
All right, we've gotten several questions also around autoimmunity and virus reactivation. And so the question is are there, what's being done to look for the possibility of a new autoimmune disease occurring because of long COVID or COVID infection? Do you think long COVID will increase the risk of a future autoimmune disease?
Yeah, it's such a great question and such an intriguing sort of area of research. So we, as you've heard me mention with my talk, there's been associations with autoantibodies in people after having acute COVID infection. So for example, there was a study that looked at adults who were hospitalized with COVID. They found that 50% of them ended up having some sort of autoantibody in blood work compared with only 15% of controls. We've been seeing that there are some antibodies that are directed at specific sort of organ systems versus other ones that might be sort of more general. And again, we're trying to learn the association between finding them and sort of relating that to what symptoms and conditions people are experiencing. We know that this is true of other autoimmune conditions. So we know that when people get a virus or some sort of infection, that even after that virus clears, the autoantibodies can continue and then can cause chronic disease. So we've been sort of accruing more data on what some of those conditions look like, trying to figure out, is there a way that we can sort of look for them? They're going to be outside of what we can do clinically a lot of the time in terms of sort of the panels that we currently have available, but definitely a very sort of active area of research. And I think we also need to know that this risk may not just be in that sort of short term within a few weeks after infection. So that's why we're doing a lot of these sort of longer term studies, enrolling people over longer periods of time to see if something might develop even, years after the initial viral infection.
Thank you. So there have been talks, some in the presentations, talk about the microvascular inflammation or the angina type pains for kids with long COVID chest pains. What are some of the tests or scans to confirm this? And then combining this with another question that we also received around the microclots and research being conducted around that and treatments, and whether there's any additional information around this topic.
Yeah, so all great questions. So in terms of some of the cardiac manifestations, we talked about how some of these can be presenting as chest pain in individuals. So some of it might be respiratory related, so more cough and respiratory system that's involved, but some of it could be related to that cardiac presentation too. So if people are exhibiting chest pain, we really want them to be referred to the cardiologists and to undergo a cardiac evaluation. So that usually looks like getting an EKG, looking at the heart rhythm, and then potentially going on to getting an echocardiogram to look at sort of the structure and the function of the heart. And then sort of the next steps is just kind of ruling out other potential reasons to have chest pain. So is it respiratory? Is it sort of related to the GI system? What we're seeing in kids is not the same chest pain as what we might be seeing in older individuals, where there might be ischemia or parts of the heart that are sort of damaged because of clots in the larger coronary arteries. We're seeing different kinds of manifestations that might be more sort of global inflammation of the heart. So myocarditis was something that we talked about, or completely normal sort of echoes, completely normal EKGs, but still these ongoing symptoms that we can't necessarily pick up on our clinical testing. And so for some of these folks, we need to be very careful in terms of they're sort of returning to playing sports. We want to make sure that we're not going to exacerbate things in any way. So that for that reason, we sort of talk about referrals to cardiology. They can help with some of those return to play pieces, make sure that there's nothing sort of structural going on, and can talk about whether there's any other steps that need to be taken treatment-wise. And so that's a little bit different then from talking about the microclots and the changes that we see within the vessels. So again, we call these sort of micro vessel damage. So it can be, you have a predisposition to clotting, and then it can cause some sort of distortion or changes to the lining of the vessels. And that has been shown to be associated with some of these local symptoms and conditions. In terms of what can be done about them, we know that with acute COVID, we will often give people preventative measures to stop them from having clotting problems, and sometimes they need to go on to get specific treatment if they do have a clot. It's still unclear what we need to be doing with certain conditions that are associated with the microclots. So does anticoagulation, the same way that you would do with like a large clot, is that beneficial for these patients? Because obviously there's going to be sort of risks with any sort of procedure that hasn't been studied well. So I think more to come in this space. So we'll see if there's any directed treatments to sort of help any of those symptoms down the road.
I think the only to add is that there have been some interesting recent studies that have looked for microclots in the muscle. So not only in the vasculature, but whether that might be part of the link between long COVID and other post-viral conditions and post-exertional malaise. So, well, as Dr. Rao said, many much research still needs to be done as we're trying to piece this all together.
And on that note, we've got time for maybe one or two more questions here. And this is one that's very forward thinking in terms of whether there's any proposed studies that use whole genome sequencing to search for genetic variations, which may predict PASC in kids, just given the quest for a unique diagnostic protein biomarker will really be futile given the plethora of systems and symptoms involved. So I think this might be a question to Dr. Stockwell.
It is actually a wonderful question. It is something that is part of Recover, is we are collecting many different kinds of samples, but including doing some whole genome sequencing as well, because I do think when we're looking for potential risk factors, not only for long COVID itself, but also for recovery, which is really important to all of us. We want to make sure that we're looking and at multiple levels. So there's the kind of the social, the biological, and as well as the genetic.
And then just to close us out, Dr. Case, can you speak to a little bit about how long COVID in pediatrics is evolving in this post-Omicron, and just kind of wrap us up with that today?
Yeah. So I think the way that we're thinking about post-COVID or long COVID conditions really stems from the fact that we don't have a great baseline or information to start from. So it's a little bit of learning as we go, and that's been a big challenge. But I think one of the things I wanted to mention is the MISC, our multisystem inflammatory syndrome in children, was something that I saw as a consultant in the ICUs for a fair amount in the beginning, and even during the Omicron wave, and then that kind of trickled out. And so I think knowing that that is one of the phenotypes of PASC, it's shown me that things have definitely shifted and evolved, and potentially there are, subclinical or more mild MISC, but it's not to that degree where they're requiring ICU care. And so I wonder if everything has just shifted a bit. And alternatively, or I guess in addition, we've also still seen a couple cases of MISC, but it's been in children under 2. And so I wonder if this has been their first exposure to a SARS-CoV-2 infection, whereas maybe one of the larger takeaways is that a large portion of the population has been exposed or vaccinated. And so anyway, that's a great question. It has evolved. And I don't necessarily take it to mean that the outcomes are more mild, but I haven't seen as much as a consultant in the ICU type arena.
Thank you, Dr. Case. And thank you so much to our presenters and our audience for attending today's seminar and really engaging with the question and answer period here. As a reminder, a recording of today's seminar is going to be available on recovercovid.org in the next few weeks. We'll also be posting a Q&A document that has responses to the questions that we received today, including those that we did not have time to address. So we hope that you'll return and join us for our next session on May 14th when we discuss SARS-CoV-2 infection during pregnancy and the development of long COVID. So please take a moment to visit the R3 page on recovercovid.org to register and receive more information on upcoming sessions. And additionally, before you leave, you'll see a short survey come up on your screen, and this will ask for feedback on this seminar, and it just popped up on mine, so you should see that as well. And it popped over my script. There we go. So if you could take a moment there to fill out that brief survey, that will help our planning for future seminars as well. Thank you and have a great day.